I've got a few slides, but what I really want to do is sketch out a very simple narrative. The policy challenges we face really haven't changed over the last several decades. It's the same issues that showed up in the 1970s, that show up in the 1980s, that show up in the 1990s, maybe with a bit more feeling now and a bit more vigor and a bit more impatience, but it's the same issues. So we shouldn't be surprised that the policy responses to these issues haven't changed much either. And the same broad themes of more integration or more accountability really haven't changed either. New models that we see from the United States, like accountable care organizations, appeal to us because they seem to maximize both those policy directions. They promise greater integration, and they also promise greater accountability. They match, though, a political imperative that has become more and more urgent recently, and that's the desire to shift risk away from the payer and actually onto the system. And so they appeal for that reason as well. They follow that new political logic. I'm going to talk a little bit about whether or not we're better or worse prepared here in Canada to adopt these models, but also what are some of the key elements in terms of capacity that we'll need to adapt to these models, and also what won't be fixed by these models. So the point that the policy changes or the policy challenges haven't changed much was brought home very, very forcefully a little while ago, not in Canada, not in the United States, but actually in Europe. So the Journal of Health Economics, Policy and Law did a whole issue that said, so what's really changed? And the point was made in the lead-off article that these big issues around aging, or at least the perception of the importance of aging, around technology, around patient demands, around chronic disease, have been with us now for a long time. Looking at what we've done in the response, changes and challenges and opportunities around integration, we've come up with new different organizational structures. In Ontario, we have LHINs, and just about every other jurisdiction has some greater degree of regionalization than we do. And also the idea of accountability for more, and recently actually better care, has been a constant theme as well. And you can see this reflected over time through notions like scorecards, through notions like accountability agreements, and also an incredible focus, starting really back in the 80s or earlier in Canada, on quality improvement. These have changed, though, over the last little while, I think really because of some very profound recognitions or realizations within payers. The first is the system's too tough to manage centrally. And so my first minister used to say that you can't manage the Ontario healthcare system from Queen's Park. That hasn't stopped governments around the world from trying for a long time, but it's become clear that it is just too hard to manage these technical issues, no matter how large or how sophisticated the bureaucracy. The second, I think, is a realization that there's very little credit for good management. And I think most ministers of health and all of their staffs finish a tour of duty in a Ministry of Health wondering why no one gives them credit for what's actually been achieved. And so there's this sense that you shouldn't be trying to manage as well from a political perspective. And finally, and we saw this reflected very clearly in Julian Legrand's influence at number 10 Downing Street in the United Kingdom, which you can see it through a variety of policy shifts around the world, this idea that if demands by patients and the public are so significant, let's turn that away from government and onto the system and actually engage communities to try to drive some of this change as well. And so a political imperative of really moving risk away from the payer and onto the system as much as possible, and really trying to turn the challenges that the system or the population present back on the system itself. And so accountable organizations are very appealing. As I said, they seem to promise greater and greater integration. This idea that as we bring together doctors, hospitals, nurses, community-based institutions, together to manage trajectories of care rather than encounters of care, well, that seems to maximize the integration angle. And because they now become responsible for both the costs and the quality of care, that seems to maximize the accountability agenda through that very explicit transfer of risk now. But you can see, and I think it's important to look at this, the same issues that will affect accountable care organizations affect just about every other policy venture that we've had over the last 20 or 30 years. And whether we want to talk about the challenges of measuring performance, those pertain to accountable care organizations. Whether we want to talk about regionalization and the challenges around governance and the alignment of providers, those pertain to accountable care organizations as well. These aren't new policy issues. So underpinning all this, though, is the idea that quality costs less. And we've got this new term, value in healthcare, that everyone likes to talk about. And it's a used and it's an abused term. So one of the things that we should consider in all of this is whether or not quality does actually cost less. So John Overtveit, in a recent review for the Health Foundation, looked at this question, and the broad strokes of the conclusions are pretty clear. There's a lot of bad quality that costs a lot. It actually probably can be cheaper. But fundamentally, and I think this is important, the benefits don't accrue always to the actors. So what primary care does better sometimes benefits the hospital. And what the hospital does better can benefit primary care. And so as that sort of blowout that we've got there, the point is made that this isn't necessarily just about asking people to do better and save money. You need to make sure that you bring together groups of providers, and you need to make sure that they invest and are rewarded proportional to those contributions. But it won't happen within their sector. And there is some emerging evidence, and I should probably say may rather than can here, but there's some emerging evidence that this accountable care organization model will work. And so there's been some initial pilots, and you can look at the experience in California, or you can look at the experience through the Brookings Dartmouth efforts in the United States, that these accountable care organizations can work very well. But this isn't new evidence. This dates back to 1991 and some of the Medicare pilot programs back then around AMI and other conditions that showed, well, with a focus on quality, organized around a patient, not around an institution or a sector, but organized around a patient, that you actually can save money. But there's also a question of how far this model can be pushed. And so Uwe Reinhardt made the nice little point a while ago in one of his lectures that ACOs are about as close as you can get to Kaiser Permanente without calling it that. And Mark Smith, who runs California Health Foundation, made the point as well, ACOs are like unicorns. They can do an awful lot of stuff, just no one's really seen one yet. And so there is this issue, just how far you can push this model. And my colleague Sarah Singer at Harvard's made the point very well that we can't overestimate the capacity of the system to pick up on this. This isn't a field of dreams situation where if you build it, they will come. There actually has to be the investments and the allocation of capacity to do all of this improvement. We should not expect that, despite the intellectual capital resident in our healthcare system, that it can adapt instantaneously to these changes in policy. So what do we actually need to do in Canada to start to move towards this model? Well, the first is actually a functional architecture that reflects not institutional boundaries, not political decisions, not administrative lines that we have within our world, but actually organization of care around the patient. My colleague Therese Stukel at ISIS has worked hard to actually develop these sorts of areas based not on where county boundaries are, but where actually people get care. And you can see they actually seem to fit into a manageable size. Even in a large province like in Ontario, we've got an average size of these organizations of about 150,000 people. We've got a manageable number of providers who can be brought together. We've got a manageable number of visits. But again, building on the previous presentation, there's actually a natural unit here that can both maximize quality and cost perhaps, but within a manageable governance structure that looks very different from our current regional structures around the country. Second is we need to decide what we want to achieve. And as we aggregate more and more providers, as we increase the degree of integration, the benefits will actually increase as well. So if we want to do with adverse events, we probably need to deal with the docs who work in hospitals, the professionals who work in hospitals and hospitals. But as we start to push out and deal with readmissions, we need to have community-based providers into that. When we start to deal with chronic disease, we probably need to bring drugs into that, which has typically been one of the solitudes of our healthcare system. My friend Nitish Chowdhury at Harvard recently showed that if we actually provided some drugs free, separated them out of this silo of different coverage decisions, well, we'd actually help a lot with chronic disease management. And as we move into a whole bunch of the other challenges you see walking down the screen, the list of providers who need to be brought into this governance structure and the sectors that need to be brought into this governance structure actually increase as we go along. So we need to decide what we want out of here, which is actually a big shift for healthcare systems. And in some ways, actually, we're better suited to this from a policy perspective. If you look at some of the rules and the regulations and the rather elaborate processes that have rolled out in the United States, a lot of that has to do with how you cope with the corporate practice of medicine, which we have a much gentler approach here in Canada. We don't have a significant and anti-competition statute. We have very different self-referral laws that reflect both our history and our geography. But we lack the same issues around capacity. And this is both the technical capacity, whether or not providers can communicate with each other. We are still a long way from an interoperable electronic health record in this province or in this country that would permit the exchange of information. But we're also a long way from the types of mature governance structures that we need to bring these people together and bring them together in a way that they will trust each other and focus on the management of patient and not the allocation of some small amount of savings. And actually on the capacity across our system to improve. And I think everyone likes to come back to the Toyota example that in Toyota everyone's job is to hit the standard and raise the standard. That's true. Everyone working is expected to contribute ideas for improvement. But there are also people whose job is improvement. The people who understand the production process, but it's their job to help accelerate all those changes. And so capacity is a critical issue for improvement that we will need to actually respond to these models. We should also not assume that this will fix our healthcare system, or even that it will touch on all the things that make our healthcare system important. As you actually change the vector of value, economists would talk about value being a combination of a whole bunch of different things that we want to improve in our system. It's not just better quality, not just lower cost, it's things that may be orthogonal or move in different directions like a patient experience, or even equity, which is a defining characteristic of our system. Well, it will actually have different implications for savings. We may save a lot from reducing readmissions. We may not save a lot from improving patient satisfaction. And perhaps most importantly, we won't necessarily see the reduction of inequalities within our system. So my colleague Arlene Bierman's had a study actually supported by Pat Campbell's here today's organization for a long time called the Power Study. This has looked at inequity and inequality in Ontario. And the fundamental thing that for me has come out of this study is that the differences in health that we see far exceed the differences in access or quality of care that we see. There are ways to deal with this. There are hospitals that reach out to their populations and bring in those populations and try to organize care. There's models like community health centers and other groups that try to bring the broader determinants of health to bear within a health setting. But those are not necessarily going to be places where even in the most extreme type of integration I've talked about here, the benefits will actually accrue in terms of savings to the same organization. And so they won't necessarily deal with inequalities. So, as we go forward, what is it that would be important to do in this country? The first is to set an architecture organized around the patient. We far too often organize our architectures through political fiat or through administrative boundaries or through some type of system that makes sense on paper but doesn't actually follow the experience of the patient. We also need to redefine the relationships between payers and providers. So Mark McClellan makes a very good point looking at the ACO experience that it seems to be working where the payer and the provider work together. And that requires a redefinition of the often antagonistic relationship between those two groups within our system. Second is we need to figure out measures of performance that reflect integration. Hospital report cards are actually relatively easy. They're relatively easy to construct, they're relatively easy to communicate, and they're relatively easy to share and to even point and hold someone accountable. We actually need measures that reflect the patient experience. And finally, we need to actually de-layer and de-bureaucratize the system. I'm not talking about this or that administrative structure. I'm talking about all the rules that get in the way of building capacity to improve and get in the way of talking about what we want to achieve and instead focus on how we're going to do it. And if you want to see sort of the contrast of what these two examples look like in this country, you can look to Ontario. We have a wonderful, detailed regulation and law on long-term care. It's larger than most phone books. In fact, I think it'll become the new standard when you talk about tearing something in half to show how strong you are. It will be actually our long-term care home law, not actually a phone book. And it talks about how to do it. If you look at the Excellent Care for All Act that Terry's already talked about Bob's role in that, that's a 20-page act, even with all of its regulations. And it focuses more on what should be achieved. And that's going to be a major shift in how we manage our system, and will hopefully reflect that shift in political dynamic. But we need to actually de-bureaucratize the system so that people can focus on improvement and not actually on process. Thank you.
Well, good morning, everyone. I wasn't totally sure that I should accept this honor to follow Adalsteinn Brown. Whenever someone is introduced as a Rhodes Scholar, you know you're in trouble when you're not. So I'm not. However, so I met with Adalsteinn ahead of time and said, Adalsteinn, what are you going to talk about? Because there's no way I'm going to be able to make it up sort of sitting in the chair. So we had a good discussion, and Adalsteinn indicated he's going to talk about accountable care organizations and how that might be a model that we can embrace in Canada. Can I actually have his slides off and kind of move to mine, if you wouldn't mind over there? I'd feel more comfortable with that. So there, I'm at home now with my angel looking over my shoulder. My problem was I actually didn't really know what an accountable care organization was. So maybe there's a few in the room here who are in the same position. I've been somewhat ignoring what's been going on in the United States with respect to that model, and kind of spending a lot of time thinking about what I could do at St. Michael's in Toronto. So, but it was actually useful to do, because it made me go back and sort of think about these ACOs and what are they. And one of the first things I came to understand is that the group that developed them in the beginning were from Dartmouth. Well, that was the clue, because Dartmouth is totally tied into the IHI. So now I was feeling a little more at home, because the IHI, the Institute for Healthcare Improvement in the United States, is a fantastic group of thought leaders who are sort of thinking about how do we improve healthcare in our system, and many of us in Canada have been going to their sessions and following some of their good advice going forward. So I would suggest that actually the ACO is a spin-off, if you like, on the IHI's triple aim. So the triple aim has three parts to it, right? The first is they call it patient experience, but it really is a surrogate for quality and quality improvement, which the IHI has been pushing for a long time with some really good ideas about how to improve it. Cost, all right? You got to reduce cost, not independent of quality. We have to reduce cost. And then the third aim is population health. And in my mind, that really says we need a system. We need to stop thinking in silos, and we need to work as a system. So the IHI for the last 5 or 6 years has been talking about the triple aim. And I think that it really is the bedrock for an accountable care organization. And I guess to expand on that a little bit and start with quality. Quality improvement is something I've dedicated myself to at St. Michael's. I actually have no choice now, since the government legislated that I had to do it, and actually tied a piece of my income to my success at it. So, so if I wasn't committed, I sort of got a little more committed. And my board, of course, is keen on this. So the actual creating a legislation in the province of Ontario saying you had to do this was actually useful. Got everybody's attention. If you weren't thinking about it before, you sure are now, and boards are thinking about it. The problem with quality improvement is not so easy to do. I could talk sort of for the next hour just about quality improvement and how do you actually do that in a hospital or anywhere. Because it means change, and of course we all know that change is the worst possible thing you can say to someone. Everybody agrees that change is really important. It's just it's all those other guys, right? I'm really good where I am, but everybody else should change. So that's everybody's view. So how do you actually overcome that and start to get change happening? So it's not easy. I put up here 3 things that I think are essential. And actually, everything I say I'm stealing from somebody, and a lot of it's from the IHI. So if you haven't read the 7 Leadership Leverage Point white paper from the IHI, you should. The problem was that it has 7 points, and you can never remember what they are. So I've made it down into 3. So these 3 things are the 7. And if you look carefully, at least 3 or 4 of the 7 are leadership, right? Board, CEO, leaders, CFO. The leaders in the hospital have to be totally committed to this, or nothing's going to happen. Flip to the bottom one, engagement. One of the things that I think people forget is that it's frontline staff and physicians who have to change what they're doing. It's not some person in a quality office somewhere thinking up good stuff and then putting it out and then putting something else out and then putting some. Frontline staff have to be doing stuff differently. So that's where the focus is, and you can never forget that's your target audience. They have to change. But the secret sauce, and you probably all know this, so I'm sorry, but the secret sauce for me is the one in the middle, and it's called, I've got structure, but it's the infrastructure. People don't know how to change. You actually have to give them tools, something that facilitates their ability to change. And that means you have to actually spend some money and hire some people who are, process redesign experts, project management people, data. If you can't measure it, you can't change it, right? So you have to have people who are good at analyzing data. So it costs money. And the problem with that, of course, is in a big hospital like St. Mike's, we can actually find the money to do that. If you're in a really small hospital, this is a big problem. So I think one of our system problems is how do we help out the little guy who can't actually afford. In fact, if they could afford to hire these people, they're probably got, in a sense, they got too much money. So I think the infrastructure piece is a huge issue on the quality improvement piece, which is, seminal to what accountable care organizations have to do. They have to do things differently and better. So the second thing is, the second part is cost, right? So irrespective of whether or not we're improving quality, we need to reduce costs. Things need to be cheaper, and I think the list here is not new to all of you. These are things that we all have to just start doing, right? So we need to, back office where it's appropriate, start putting them together. We need to think about our clinical care programs and whether we should be into them all or partnering with other people. Group purchasing, the list, and I'm sure there are more things you could put on the list, and I suspect that everybody's doing this, but I think we have to actually do it even more, right? We have to reduce costs wherever we can, and this has nothing to do necessarily with quality or quality improvement. It's always been a tough one with the docs, because the docs always, docs particularly are ones who poo-poo cost reduction. You can get them interested if you talk about safety and quality, the dimensions of quality, but they're really opposed to cost reduction. But I think that's changing now that we don't have any money and they get it that we're going to actually shut down that operating room or close that clinic. We sort of have their attention, and I think now's the time that we really need to move on some of these cost reduction initiatives. So the second part of the triple aim. The third part of the triple aim is the systems piece, population health. And I'm sitting in an acute care hospital, which traditionally has been pretty good at being isolated. St. Mike's, and in fact, we were criticized for that for a number of years as being really good at being hunkered down and doing our own thing all by ourselves. And obviously that's not great for patients. So we have to move the model, and we have to start figuring out how we're going to link with all of the other aspects of the healthcare system. And in every province, you have regional care. We have LHINs, which we love to talk about. LHINs is regional care light or whatever it is. It at least has had the benefit of making us start thinking about this, and there have been some spontaneous sort of actions that have come where some of these different sorts of agencies or institutions have started to either hook up formally or informally, which is obviously going to help for the patient care stream. So all these three things are crucial as parts of the accountable care organization if we're going to have one. And you have to be working at them all, and I think you can think about them in those three buckets as you move forward. But there's one other thing that is really different in accountable care organizations that we don't have in Canada, and it relates to the funding model. So we have, on the left-hand side, we're base budget funded institutions for the most part. So we get our money at the start of the year, and we make sure we don't spend a nickel more by the end of the year. So we're not volume sensitive. In fact, we can control that spending by modifying our volumes down to, so I can close an extra OR over Christmas or in the summer holidays to save money, to stay within budget. Obviously, that's decreased volume of care. So we're in our system, patients are a cost center, right? I see a patient, I see money going out the door. So I'm not incented to accept that patient from a financial point of view. Now, it's a little different for docs, because most of our docs, now it's changing in some ways, and certainly in primary care we have a new capitation funding model, but most of our docs are paid fee for service. So it's the exact opposite. They see a patient, they see a dollar sign coming in. So we have this tension between the docs and the institutions, where we're trying to sort of limit how many patients they bring in to stay within budget, and they're trying to maximize the number of patients they bring in to maximize their income. And that tension is something that, skillful CEO, that's how you make your money, actually, is managing that tension interface as a hospital CEO. But in an accountable care organization, it's actually moving to another model where funding doesn't come like this. Funding actually is tied to the patient. Now, the problem they're having in the States is that they already have the model where the hospitals are funded fee for, patient is revenue. And so the docs in the hospitals are aligned already in wanting to accept that patient. The problem they're having, and the one they're talking about, is this whole issue of appropriateness. And, are we now sort of driving care that's maybe unnecessary, and how do we manage that? So ultimately, the model of the accountable care organization, however, is a capitation kind of payment model for both the provider and the institutions, and in fact, multiple institutions together, as Staney suggested, sort of pooling all of our costs, if you like, and pooling our activities and accepting an annual fee for a population of patients. So moving from where we are today to that is, I think, going to be the hardest thing of all. In Ontario, we understand as of Monday that maybe it started. So many of us are exceedingly anxious about what that might mean, because they're starting to talk about changing our funding model away from just here's your base budget plus 1% or plus 0% for next year, to your base budget's now dependent on the work you're doing, and we're going to actually allocate you some money against that work. So it's starting to feel like volume-based payment. The problem is getting from here to there. They did this in England, so I asked the question to I forget, what's Jim Elliott, Staney? We were at that meeting, and said, so how did you do this? And he said, well, it wasn't that hard, because what they did is they had 10 billion extra pounds of money that they were pumping into the system. So instead of changing your base, they got you to chase the new money in the new model, right? So you're now getting new money, but you get it like fee for service, right? So you had a base, the old money, new money, fee for service. So it was add on. It didn't sort of take your pins out from under you. The problem we have certainly in Ontario is there's no money. There's no new money. So in order to change to this model, they actually have to take away your base somehow, and then ask you to earn it back in a different way, in a sort of a fee for service kind of way. So the devil's in the details on that one, obviously, and I guess we'll see how it goes. So for me, the big challenge here is going to be moving the funding model to one that, if we're going to go to an accountable care organization in its fullest form, is the payment issue for all of us. So just my last slide is just to put the four things down, just to say that we can do quality improvement. It's not easy, actually, but we're all on that journey, I think, across the country. We can reduce costs. I think we've been on that journey for a while, but we probably have to step it up. We are, in some provinces, you're ahead of us on your ability to integrate across sectors. On Ontario, we're still struggling with that, and we'll see if the LIN reform comes to help us get that done. But the big one is going to be how we get paid as institutions, if we can move that model across. So those are my thoughts about an accountable care organization. And Terry, what's going to happen next? I'm done.
Maybe as a precursor to the fireside chat, I could ask you and Staney to sit here. You're both mic'd. We have a few minutes, so Perhaps I can just stimulate the exchange by putting a question to our colleagues, but then I'm going to put a couple of questions to folks in the audience just to get us started. Accountable care structures, better integration of care. One thinks about Quebec. The history of health service reform in Quebec, dating to Castonguay-Neveu, is exactly this vision, 1970. First province to regionalize, first province to integrate health and social service, first province to try to articulate a structure across first lines of care with the CLSCs and so on, and many, many layers of innovation between there and now. In Ontario, and I'm just going to use the Quebec and Ontario examples as a start point, but the same is true in other provinces. In 1992, first recommendation of well-detailed recommendation about how to regionalize and integrate services from the Premier's Council, and then the emergence of LHINs about 15 or 16 years later as an answer to this to try to integrate services. So first of all, maybe to Bob as a response. Steny, you may wish to comment too. And then I'm going to invite comments from Camille Orridge, David Levine, and Chris Power from 3 different regions in Canada to comment. So let's assume the thought experiment again. We're rethinking integration and accountable care. We bundle together acute care, tertiary institutions, secondary institutions, but we also bundle in what was hinted at in Ontario, but I don't actually believe that's what's going to happen, the bundling in of primary care services as well into a regional envelope. So now you have the entire spectrum in a regional envelope, which has never happened in Canada. We've never had primary care properly integrated, and we've had various shades of kind of community service care. So again, sticking with the thought experiment and the idea that if we can actually keep all the risk in the provider pool, we can actually find a way of making more efficient to squeeze out, as Bob was characterizing it, some of the areas where we may be able to extract some resource and reallocate some of the resource to where we need it. So perhaps first, Bob, your reaction to this thought experiment. I know you're still reeling from service-based funding as an institution, but think about within the Toronto Central LHIN, if you had your primary care providers bundled in with an envelope so that you, they, and the community service providers all had to share risk in terms of a common pool of funding for your region.
So I think there actually is a way to do it, and I actually think that the hospitals should take the lead. In Ontario, we have something called family health teams. I'm not sure if there exist outside of the province. I'm sorry about that, but so it's a new, they roster patients, and it's a capitation payment model. If you have 1,000 patients times $200 a patient, you get $200,000 a year, and you know that at the start of the year. And what it means is it's not fee-for-service anymore. It's like you do the right thing for the patient to care for them. So telephone medicine, and whatever works is the right way to do it. St. Mike's got into that business. So we actually have 5 family practice sites that we own in the community, if you like. So there are sites, there are docs, and they're all credentialed at our hospital. And we work very closely with them, especially around our kind of disadvantaged population, which is a difficult-to-serve population that requires extra resource for the obvious reasons. So we're already doing it, and I guess the experience I'm hearing in the province with other family health teams that are not aligned with sort of an administrative body is they're not necessarily doing so well because, frankly, I can say this as a doc, so I'll say all kinds of negative doc things. But docs aren't necessarily good administrators. It's tough to say when I'm a president of a hospital, but so I guess you have to take that with a grain of salt. But docs aren't necessarily good administrators. They're good docs, right? They practice medicine, and what we need them to do in primary care is actually organize. Somebody's got to organize the care and start doing start doing all the things that we hear about that are happening in Quebec, and they just don't have people to do that. So, but hospitals have administration staff. We've got lots of staff, and we can do that. We can organize them for themselves. And actually in our family health team at St. Mike's, they're happy for us to do this. So one model is a sort of hub and spoke model where acute care hospitals, just because we have administrative resource, can take some of this stuff on and manage it, in a region sense. So I think, the OMA might not like that, but it makes sense to me.
Shane, would you like to comment on this thought experiment idea?
So the only thing I'd say is that we have a fascination with structure in this country. And I think we often mistake moving the pieces around on the board for meaningful change. Look, ACOs are just a structure that allows incentives to be shared and really at the end of the day provides a vehicle for communication and a way of making that information important to people who actually generally want to improve. As Bob says, it's not a lack of desire, it's often a lack of capacity and opportunity to improve. So I think before we get to this idea of what the new structure is, we should actually figure out what we want in our system. We should figure out what sort of improvement is possible. And we should actually make sure that we've got the engagement of the people who are really providing the care. And then these structural things will accelerate positive change. If we don't have that, they will merely look like one more layer of administration sitting on top of people who are already working hard and don't have time to focus on the types of improvement that Bob's talked about.
Great. I think the challenge is, unless you've got all the money in a fungible pot, it's very hard to get everybody's attention once you've done all the nice overtures with all of them. So, Camille, in a moment I'm going to ask you to comment, if you're comfortable to do that, on this idea of bundling the services under a common envelope. We have to think outside of the box, and nobody's going to hold you to these comments with respect to what it means for Toronto or for Montreal or for Halifax, but just to get on the table. It's taken us 15 to 20 years to get a regionalized structure in Ontario. So despite its warts, we would want it to work, and we want it to work more effectively. And how we might do that might take another 10 to 15 years. We hope not. But what about this idea of bundling all of the funds under one roof and being able to move them with some ease between home and community care, the hospitals, and the primary care sector?
Thanks for putting me on the spot. I mean, when I look at all of the notion of regionalization light, regionalization full, I go to the other extreme and I says, okay, show me the outcome at what cost point and what's the quality, and show me who has been successful. And to date, in all the studies, I haven't seen anything at the other end that said all these structural changes have really delivered at that end. I think we need to have some population-based agenda, and who are the population, who are all the people in the population, and then bundle the funds around that population and bring those players together. Not every patient is the same, so I'm not sure why we spend as much time around navigation and all those things for the healthy population versus the one who actually need it. And in Ontario, in Toronto, there are two issues. There's the politics. So every institution, we have the big boys, we have the power players, we have the docs, we have the OMA, we have the OHA, we have the community agencies, and everyone is a power player in its own right that then fight for their wanting to be in control versus one common outcome, one common aim around a particular population. And I would think that, in some ways, is the bigger problem than the structural problems. And we don't often articulate the vested interests in terms of this discussion. So for me, that's the only way to go forward, is to actually have the money bundled. It must follow population by patients, and they've got to share the risk across. One other thing I would say is Toronto have another issue in that it serves the GTA and beyond. So 60% of who come in do not live there. And government insists on flowing money to where patients live, not where patients get care. And I think that has to change as well. And thirdly, all the people who are in the position of decision making come from a particular place. And so we are now dealing with today's 1%, but not looking at tomorrow's 1%. And tomorrow's 1% from quality and engagement don't look anything like today's 1%. So I think we're going to solve today's problem and have a bigger problem for tomorrow.
Thank you, Camille. Thanks for going first, too. David, your thoughts. Does this sound familiar?
It sounds particularly familiar. Our problem structure is dealt with. We don't have to discuss it. If we talk leadership, structure, engagement, as you mentioned, the structure part is done. We've integrated the hospital with the primary care, with the home care, with rehab services, all into one single organization, population-based, with the responsibility for that population. And we are in the process of rostering every single person in that territory to a family physician. So that's structure is done. Have we got the results that we just talked about? No. And the reason is leadership and engagement. So really, if we take it into that concept, the structure, and I'm very happy it's done. That was a huge amount of work. We don't have to deal with it. Now, if I take a look at what Alan spoke about this morning, the real issue here is, can you transfer resources from your hospital sector, from what your traditional in Quebec primary care offering of services, into the family physician's office to a multidisciplinary team to deal with your vulnerable patient, with your heavy user of the system, and to introduce prevention and promotion at that population level. Once you've achieved that, you're on your way, quite honestly. So where do we get the leadership from? The leadership is risk averse. Our real issue here is leadership doesn't want to make the move. It's dangerous to move your staff from one place to another. The professionals are comfortable where they are. They don't want to go somewhere else. And our professionals assistants certainly don't want to work for doctors out in the community. So we have a dynamic there. So the answer is, give us new money. Put new money in, we'll hire new people, and then we'll be able to achieve it. And the real leadership role here is to really move that way. In Toronto, and I enjoyed your comments, that you have a number of those primary care teams attached to the hospital. It's what's done in Barcelona. It's the exact same thing in Catalan, where they have primary care teams all attached to often university or tertiary or other hospitals. Here we've integrated those hospitals into the team already. There are 95 centres de santé in the province of Quebec. The one in Lanaudière Sud is a brand new, very interesting second-line tertiary capacity hospital with a good leadership. They were the first ones to develop the relationship between the primary care teams and the hospital to define protocols for corridors of service for entering people into the services of the hospital easier than was found elsewhere. The issue is now, how do you get the engagement? You said invest a little bit and bring in some of the people that can actually facilitate the change. I think the answer is there. I think that's what really needs to be done. And we have to find that little bit of money, and it really is a small bit of money compared to the impact and consequence of what we want to achieve. So I'm very encouraged by what's going on in Quebec. My issue in Montreal is that of the 12 networks we have, 7 of them don't have a hospital integrated, because all the university teaching hospitals tend to be in Montreal. And as a result of that, I have a great deal more difficulty in getting that link between our physician's office and the hospital. Okay? The leadership of the hospitals in Ontario, I think they're so strong and so dominant and have the administrative staff, because they have the funds to pay for that administration, have the competence to do the job. There's the resistance of the community not wanting that hospital leadership in that environment. So those are the comments from the Montreal region.
We do have a few minutes now before we have a reasonable break for coffee. Can I ask you to identify yourself as you're putting your question?
I'm here as a patient. My name's Carolyn Canfield. I come from British Columbia, but I have a lot of concerns about across the country. And it seems to me we've missed the third leg of the stool. We have the payer, we have the provider, but where's the patient? Steny spoke very eloquently about the need to change the architecture so it's around the patient. And I would suggest that the patient is an asset, the patient is a resource. and not a cost center and not a revenue center. Or maybe in addition to the cost and the revenue, because I think we do have to think about the way in which the patient integrates the work that everybody does. When we talk about breaking down silos, when we start talking about the integration between acute care and community care, we're talking about the patient path. It's the patient experience that joins all that together. So I think when we talk about integrating care around and the whole architecture of healthcare around the patient, we have to talk about empowering the patient and engaging the patient. So how do you get to that engagement? Well, there's the expertise. Patients are expert in the patient experience. Now, where are they on your committees and your boards, in your quality improvement projects? The patient is a fantastic source of innovation. Patients don't just come as sick people, and I actually like the idea of the citizen patient. I'm trying to find the right language, because this is civil society. This is the tie of the patient to the payer. It's my tax dollar. It's that part of the triple aim. But it's also my care as an individual, and it's also the way in which the patient voice represents community. The patient voice sees the social services that are outside of healthcare, sees housing costs, sees transportation challenges, and I think brings those other sectors into the conversation that are essential. We know that, social determinants of health. And then on the individual basis as well, compliance. If we're going to talk about self-care, what better method for compliance than having the patient design their own program? And one of the concepts that I keep thinking about is, instead of inventing patient satisfaction scores, what if we had a system where the patient meets with the provider asks the patient about a life goal. The provider brings techniques, services, therapies to offer the patient for making a decision to get to the goal. And it's a trajectory. Maybe I won't be able to run a marathon in 5 years, but if that's my life goal that relates to health, that's a trajectory towards good health that integrates all the preventive medicine and all the therapeutic treatment and the chronic disease that I'm struggling with because I've got COPD and I can't actually walk 3 blocks. But if my aim is to be able to run a marathon, I'm going to buy in to every therapeutic choice and every behavior that supports that. And that may be outside of the payer. That may be on my back. I'm taking responsibility. But I need your expertise and your help. So I think
it's a dangerous thing to interfere with the patient speaking, but I'm going to ask you to come to a closure shortly.
So what I would say is look at opportunities to get the patient in the room with you. And that may be the individual patient, or it may be at a policy level more collectively. And I would just say, to wind up, don't go to the patient organizations, go to the resource that runs through your fingers through discharges every day.
Thank you. Excellent.